ठीक आहे. खूप अंधार झालाय पण.
Jayalakshmi madam is there. Dr. C.D. Mishra. मिश्रा सर दिसत नाही ना.
आ जाएंगे.
ते नंबर कोणाचा आहे? ते सॅमसंग आणि दुसरे नंबर.
We are live now, ma'am. I'm sharing the screen.
All right. All right.
वाटत गेलं पण नाही होत.
Good evening, ladies and gentlemen, those who have joined here through the webinar, through our Zoom link, as well as on our Core Connect platform. A very, very warm welcome to each and everybody over here on the special occasion of Happy Learning Masterclass web series, 187th edition in association with Ahmednagar, Chalisgaon, Dhule, Jalgaon, Malegaon, and Nasik OBS and Gynae societies. Today's theme is Mixed Bag. With esteemed honor, I'd like to welcome our convener, Dr. Asa Jain, ma'am. The lady needs no introduction, but yet I'd like to mention few of her many achievements which she has under her name. She is Director, SMSA Hospital, Raipur, Medical Director, CPRS NGO, elected member of Chhattisgarh Medical Council, Zonal Chair, Foxy Food, Drugs and MSc Committee West Zone, Chairman Mission Pink Health IMA Raipur. She has many academic achievements as well, some of which are certificate and instructor in FCCS OB courses, IOTA certification from IOTA Group, certificate of competency from Gynec Academy. She has worked as President Raipur.
Enough, Piyush, enough.
There are a lot of things which I'd like to mention, ma'am, but yet I'd like to welcome you with bottom of my heart. Ma'am, please.
Thank you so much for those kind words. Before we take the program forward, let us invoke the blessings of the divine. Next slide. What happened, Piyush? We need to play the blessings. Have the CVs. I would like to welcome Dr. Rekha Rajendra Kumar ma'am and Dr. Monica Umbardhan madam, who are the coordinators for this evening. Welcome. Welcome, Dr. Rekha, the president of Bangalore Society, a really accomplished gynecologist, IVF specialist, and she's been associated with this webinar for a very long time. I would also like to introduce Dr. Monica Umbardhan. She is also a consultant obstetrician gynecologist at Mangalya Nursing Home and Athar Fertility Center. She has very many accomplishments, but more than anything else, she is always eager to help anyone who wants to really work for the society. She is the national coordinator of the PSC committee, Fox. Welcome, Dr. Monica. Now, I would like to welcome Dr. MC Patel, sir. This program, Happy Learning Masterclass, is the brainchild of MC Patel, sir, and now it has reached 187. I invite him for the official welcome address.
Thank you. Thank you, Asha. It gives me immense pleasure to welcome you all to 187th episode of Happy Learning Masterclass web series. I welcome all the societies who have joined this webinar: Ahmednagar, Chalisgaon, Dhude, Jadgaon, Malegaon, and Nashik. I also welcome Dr. Ganorkar Madam. She has kindly consented to be chief guest to bless the webinar. Of course, she is always with us in any of our academic activity, and we are always blessed. So welcome, Madam. I also welcome two learned guests of honor, Dr. C.D. Misra sir and Dr. Varsa Batse. Both have kindly consented to be guest of honor to bless the webinar. Varsa Batse, Vice President-elect Foxy, and she is also good old friend and working in Foxy since years together with us, and she is always with us in any of our academic activity. I welcome today's speaker, Dr. Jyotsna Dole Madam from Ahmednagar. She is going to discuss very important topic of CTG in our obstetric practice. So welcome, Dr. Jyotsna. And to chair that very interesting and important session, I welcome three learned chairpersons: Dr. Sujata Kulkarni Madam from Nashik, Dr. Varsa Lahade from Nashik, and Dr. Ganesh Bade from Ahmednagar. And today there is reverse panel related to pregnancy and labor related issue as far as medico-legal consequences are concerned. And to ask queries or question, all the panelists who have joined this webinar, I welcome Dr. Mayuri Kelkar from Nashik, Dr. Sangeeta Wagh from Nashik, Dr. Anjali Kulkarni Madam from Nashik, Dr. Prasant Jande from Ahmednagar, Dr. Yashwant Pawar sir from Chalisgaon, Mandar Karambelkar from Chalisgaon, Jitendra Gomre sir from Dhude, Vishal Patil from Dhude, Bansi Sinde from Ahmednagar, Preeti Poge from Jadgaon, Shashikant Vawal from Malegaon, Sachin Khedkar from Chalisgaon, and Vikas Gorhe from Nashik. I also welcome Dr. Asha Jain. She is convener in this series since long. So welcome, Asha. And two coordinator, Dr. Rekha Ranjana Kumar, President Bengaluru Society. She is also coordinator in this series since long. And Dr. Monica, she is also in this series since long. And she is always instrumental whenever we are doing any program in Maharashtra, all the societies of Maharashtra. She is always there to help us to design program and to execute program. So thank you, Monica, for the same, and welcome. And I welcome all the president and secretary of joining society, that is Ahmednagar, Chalisgaon, Dhude, Jadgaon, Malegaon, and Nashik, and all the delegates who have joined this webinar. In era of COVID-19, I started this series with 3 friends, and now it has become big family of 7,000 plus as far as Happy Learning class is concerned. And just I mentioned prior, it is 187th episode as far as this series is concerned. And usually we discuss very focused topic and some medical legal issues related to our day-to-day OBGYN practice. So to be helpful to our Foxian friend and to meet at least all the friends on virtual ground is the motto of this series. So welcoming you all. Thank you. Thank you very much.
Thank you so much, sir. Dr. Monica, have you joined? No. Sir, I would like to introduce our guest of honor, our chief guest, Dr. Vijay Lakshmi Gonarkar ma'am, who's the past president of Nasik Society. She has an excellent academic career, first in Pune University, in first and third MBBS, winner of President of India's Silver Medal at MBBS 1979, winner of Pfizer Gold Medal at MBBS in 79 and Gold Medal in MD in 1983. She has commendation by the state in 1988-89 for outstanding work in family planning.
Asha, that's enough. I think it's...
Welcome, ma'am. Welcome so much. We are really honored to have you here.
Yeah. I'm also extremely honored to be here and very happy to join in with Dr. MC Patel's program, to have you, Asha, as the convener, and to meet all other friends on this in this webinar. I really won't stand in between the speakers and everyone, and I think we wish a good success.
Thank you, madam. Thank you for sparing time to bless the webinar. Yes, over to you, Asha.
Thank you, sir. Over to you, Dr. Rekha, to introduce our guest of honor, Dr. Varsha Baste, ma'am.
Okay. Yeah, thank you. It's a very pleasurable task to me because I know Varsha since long time. I have been communicating with her and meeting in person in many of the conferences, and we have exchanged our thoughts and views. Thanks, Varsha, Dr. Varsha, for being here. We are extremely honored and we are happy to have you here. We know that you are always dynamic, very friendly, and always a very warm person to all of us. Dr. Varsha is a practicing gynecologist and fertility specialist in Nasik since 30 years. She's the director of Baste Maternity Hospital as well as Pushpa Fertility Center. All of us know that the vibrant and the current Foxy Vice President-elect. She's the past president of Obstetric Gynec Society of Nasik, chairperson of IAEC Academic Exchange Committee. That's what, International Academic Exchange Committee of Foxy, and a prestigious Anandi Bai Joshi awardee. Thank you, Dr. Varsha, and we would like to hear from you.
Thank you, Rekha, for lovely introduction of mine. Namaste, Bhishmacharya of Foxy, Dr. MC Patel, sir, for Dandanit 189. You are going to double century soon with this Happy Learning Masterclass is now a mega learning masterclass with webinar series. Since long it has been carried out, and I think more than 10,000 will definitely get joined to this mega project. And I congratulate Dr. Asha Jain also as a convener. She is a very dynamic lady and with a great academic career behind her. Rekha is a great friend, and now I congratulate Rekha for becoming the president of prestigious Bangalore Society. I am really touched by the selection of both these Rekha and Monica. They are so darling friends of mine. Monica is not there, but she is always active and she has worked so much underground. She worked so much and she knows each and every corner of among societies and all over India also. And our prestigious person, the Honorable Dr. Vijay Lakshmi Ganorkar, thank you. You have raised the standard and bar of this webinars by your sheer mere presence. And I cannot see Dr. Mishra, my guest of honor, but all my friends are seen over here. And Dr. Josna Dowley is going to talk on citizen labor, which is very, very important. The chairpersons, Dr. Sujata Kulkarni, Varsha Lahade, and all these people are from Ahmednagar, Chalisgaon, Dhule, Jalgaon, Malegaon, Nashik, my area, and I'm so proud to be part of this prestigious webinar. Dr. Patel, you are very much known for your excellence in legal advice. You have done so much of work free of cost, and in need of emergency, you are always there. So we really salute you for your exemplary work and help to Foxy. And this reverse panels with all these society president and secretaries will be definitely more giving more updates and legal advice by you. legal issues in labor is very, very important. As day to day, we are very much scared of anything can happen because of these obstetric emergencies, and anybody can sue you, and you are there to help us, and you are there to guide us also. All the president of society, president and these secretaries are there to be involved in this panel discussion. There, I'm sure there will be many take-home messages from you and all of them. Thank you. Over to you, Dr. Rekha, and thank you for making me part of this prestigious webinar. I'm really honored to be the guest of honor. Thank you.
Thank you. Thank you, Varsha, for sparing time. You are with us in this activity since long, and you are always with us in any of our activity. So thank you for sparing time.
I wish you all the best, sir. Dr. Rekha, Dr. Asha Jain, and all the forthcoming contestants for Foxy elections.
Thank you.
Thank you, Dr.
Thank you.
Varsha, for your
Thank
good
Thank
wishes.
you
on
so
the-
much, Dr. Varsha. Thank you.
Thank you.
So,
God bless.
so now, sir, Dr. C.D. Mishra, sir, will not be joining.
Okay.
He is a practicing gynecologist in Ahmednagar since the last 35 years. Past president, Ahmednagar Obstetric Gynec Society, and past president of IMA also. He was the first to start NDBH in Ahmednagar and has done around 5,000 major surgeries in the rural area of Ahmednagar. He also started gynec surgery at many taluka places, but due to some inevitable circumstances, he is not able to join us, but we know we have his blessings. So over to you, Dr. Rekha, to start the academic session.
Yeah, thank you, Dr. Asha Madam, once again for this opportunity. It is a great opportunity and a very happy time for me to introduce the three great chairpersons for this session 1 on CTG in labor. All of us know that it is such an important topic. Dr. Sujata Kulkarni Madam is a chairperson. Madam, thank you so much for honoring us with your blessings and chairing the session. Madam is the director of Sita Nursing Home in Nasik, past secretary of Nasik Obstetric Society, and past president of the same society, convener of the International Gestosis Conference in Nasik. Madam, thank you so much. We would be very happy to have you here. Dr. Varsha Lahade. Dr. Varsha is MBBS MS FICOG, Director of Prayag Hospital in Nasik, past President of Nasik OBG Society, and past Joint Secretary of IMA and awardee of Best Paper Presentation in AMOX 2004. Thank you, Dr. Varsha. We are happy to have you here. Another chairperson is Sir Dr. Ganesh Pade, sir. Sir is MBBS DGO FCPS as well as an endoscopic surgeon, president of AOGS, past secretary of the AOGS. Sir is the director of Bade Hospital. That basically, sir has done a lot of work in Ahmednagar Society as a secretary, and also the past in charge of OBG department of Civil Hospital in Ahmednagar. I request all the three chairpersons to be here and chair the session for this first talk, that is CTG on labor. And I request the chairpersons, the chairpersons to introduce Dr. Jyotsna Dhule and take the proceedings and continue. Thank you. Dr. Varsha, Dr. Sujata, and Sir Dr. Ganesh Pade.
I think Dr. Sujata can introduce
Yeah,
Dr.
Madam,
Jyotsna Dhule.
unmute yourself, Madam Sujata Kulkarni. We can see you there.
Hello,
Yes,
can you
madam.
hear me?
Yes,
Yes,
now.
we can.
Yes, there is some problem with the connection.
Yeah,
Yes, yes. Good evening to all for this very important topic, and thank you, Dr. Patel, and all the organizing committee for incorporating me in this very nice topics. So here we have Dr. Jyotsna Dhule from Ahmednagar, who will be enlightening us on the NST. Now, NST or CTG is an integral part of our day-to-day labor practice, and we are all very eager to listen from her about the nonsense and the details and how to use for its maximum utilization. Over to you, Dr. Jyotsna.
Dr. Varsha Lahade is there?
No.
I can't see her. That's
Can
why.
you hear me?
Dr.
Hello?
Bade is there, but he can give concluding remarks.
Yeah. Dr. Ganesh, sir? Okay, fine. Thank you. We can proceed with the talk. Dr. Jyotsna?
Yes.
Yeah.
Good evening. Can you hear me?
Yes,
Yes, yes,
Yes.
loudly.
Yes. Good evening, everyone. Hi, Varsha. Good evening,
Hi.
MC Patel, sir.
Good evening. Good evening.
Today, my topic is CTG. Actually, this topic is selected by sir, and this topic is needed for everyone, means the senior consultant, students, and everyone. But neglected, there is controversy also, okay, whether should we go with CTG or not. But actually, in this era of medical legal cases, this CTG tracing is really important. And now I'm going to throw a little light on the CTG. Slide share.
Dr. Jyotsna
Yes,
Dole had
just
organized AMOGS very well, and she was really wonderful. She is a wonderful person, dear friend also.
how to share the slide? My slides are not getting shared. Just a minute.
Piyush ji, please allow ma'am to share screen.
Hero button.
Ma'am,
No, no,
there
but
is there
Ma'am,
will
I've
be
made
one
her the,
green button at the bottom of your screen.
yeah, I have made her
yeah,
the
but
co-host.
not.
Co-host
Share
नहीं थी वो,
screen
अभी
is what you
co-host
will
बन
see
गई.
at the bottom of your screen.
You can see that green button, Dr.
Yeah,
Jyotsna.
no. Green button is not seen here.
Share screen
That's
will be seen, ma'am.
no. It is not seen. That's why I asked.
अरे उसको co-host बनाओ ना.
Ma'am, she's already the co-host.
Okay. तो एक काम करना फिर तो
Login करना पड़ेगा
you
शायद.
send him your talk, you send him by mail.
I have sent it to
Slide.
Asha Jain ma'am actually.
So
You
Asha
have
Jain
then,
sent
will
the
check
presentation
Then
to me,
Asha,
ma'am.
Asha can assist.
Jyotsna
Jyotsna
ma'am,
ma'am,
can you
have you
please?
sent it to me?
Yeah, madam. I sent you
WhatsApp or
no,
mail?
WhatsApp. And on WhatsApp I have sent because I don't have your mail ID.
Jyotsna ma'am, can you please check again? It must be showing share screen now.
No, it's not showing. That's what.
तो करने वाले को भेज दो नहीं तो.
Why it happens? Because it should be seen.
Yeah.
Actually, every time it sees, but today it is not seen.
एक बार log out करके log in
Yeah,
करना
ma'am. Can you
पड़ेगा
please
शायद.
re-log in?
Yeah.
Yeah. Then it will
आ
show.
गया.
आ गया ना.
आया क्या?
हाँ.
Yes,
अभी
yes, आ
दिख
गया.
रहा है. सब सही है.
Okay. But that button is still not there. Green button.
God is great. चलो.
But you can move the slides, na?
Yes. I'll just check
But
it.
no, if you can move slide, then you can go ahead. No issue.
Yes.
No,
आ
the
जाएगा.
slide share is not there. Slides are not moving.
Actually,
त्याच्या
Asha
वर
ma'am
double
has
click करा.
shared the slides.
आ गए हो रहा है. No. हाँ, this is from Asha
Jyotsna
का
ma'am.
है वो.
Jyotsna
त्याच्या
ma'am,
वर
I
Acha.
am sharing the screen.
Okay.
You just speak. I will share.
Okay, madam. No problem. Okay.
This
Next
is the
slide,
PPT
please. So
from
my
Corona.
topic is CTG in labor. Next, ma'am. Next, please. So, cardiotocography is a technique used to monitor fetal heartbeat and uterine contractions during pregnancy and labor. During pregnancy, we just monitor the fetal heartbeat, and in labor, we monitor fetal heart rate with uterine contractions. And the machine used to perform the monitoring is called as the cardiotocography. The same, ma'am, please, next. The principle of CTG is it is mainly used to prevent the fetal hypoxia and fetal distress. It can be done antepartum or intrapartum, and CTG may be a traditional CTG, that is we mostly call it as a NST or computerized. And nowadays AI is also introduced, so artificial intelligence is also doing the CTG nowadays, and they are trying for it. So indications for CTG in antenatal, third trimester, it is mostly done in third trimester. We can do it after 26 weeks of pregnancy, but the false positive or false negative results are most common, and fetal bradycardia is mostly seen before 28 weeks of pregnancy, so mostly done after 30 weeks of pregnancy. Abnormal CTG in such situations may need further investigation because we cannot rely only on the CTG monitoring. And in intrapartum cases, fetal distress and fetal hypoxia can be diagnosed very well with this CTG monitoring. Next. So in this CTG, the continuous recording is done by placing the two probes on the maternal abdomen. Via ultrasound transducer, we can detect the fetal heart rate, and the other tachograph is used on the fundus of the uterus, and the uterine contractions are recorded through it. CTG is widely used in pregnancy as a method of assessing fetal well-being, predominantly in high-risk pregnancies. In high-risk pregnancies, it is very important. Next slide, madam. Two transducer, as I have said, they placed on mother's abdomen. One records the fetal heart rate and the other monitors the uterine contractions. Next, this slide is repeated again. Steps of external monitoring are: first, explain the process to the patient and relatives and explain the reasons of the CTG. The consent is not necessary, but the verbal consent is essential in these cases. First, see the lie, the presentation and the position of the fetus. Then place the two transducers transducers on the abdomen for external monitoring. Document FHR pattern, date and time, gestation, and indications for the monitoring on the CTG paper or keep a record of it. And the speed of the paper should be 1 centimeter per minute. Next slide, please. Components of the fetal heart rate paper are, this is, I have seen just now showed, this is shown in this chart, the time, and the dark line, between two dark line, the area is around 1 minute. Next, please. Then how to read the CTG? To interpret a CTG, a structure method of assessment is needed. The most popular structure method of remembering the CTG is acronym Dr. Sri Bravado. C Bravado. In C Bravado, this is the short form, and this is very easy to remember how to read the CTG. DR means define the risk. C for contractions, BRA for baseline heart rate, then V for variability, A for accelerations, D for decelerations, and O for overall impression. Next. Next, please. Next slide, please. So first of all, we have to define the risk. First, note that if this pregnancy is high risk or low risk, if the pregnancy is very high risk pregnancy, we have to give attention, very careful attention to such patients, and in such patients, repeated CTG may be required. This high-risk pregnancy may be due to a maternal medical complications or obstetric complications. In maternal complications, it is like gestational diabetes, hypertension, or asthma. And in obstetrics complication, it is not the complication but high-risk cases of obstetrics like multiple gestation, post-dated pregnancy, pregnancy with previous cesarean section, if there is intrauterine growth retardation seen on ultrasound, if there is history of PROM, then any congenital malformation is seen, or if the oxytocin induction is done for labor, or the labor is augmented with oxytocin, and the cases of preeclampsia and eclampsia cases. And the other complications are, if the patient comes for the first time, if the proper history is not there, if bad obstetric history is there in such patients, if there is history of smoking, drug abuse, alcoholic patients are there, then all these pregnancies are high-risk pregnancies and careful monitoring is needed in this patient. Next, please. Now the next is C for contractions. Now in this chart, we see that there is a recording of the contractions, uterine contractions, and the fetal heart is seen according to me. This is the intrapartum NST. Record the number of contractions present in 10 minutes of period. Generally, the tracing is taken for 10 to 20 minutes normally, and if the high-risk patient is there, sometimes the continuous monitoring may be required in such patient. In this tracing of paper, each big square on CTG chart is equal to 1 minute. So note the contractions in 10 minutes. Assess the contractions for the following parameters like duration of the contractions, how long the single contraction lasts. Intensity is assessed by the palpation on the maternal abdomen, and this intensity is carefully assessed because there may be a variation if the patient is obese, and in such patient it is not possible or it is not means accurate to see the intensity in obese patient to judge the intensity. So in this tracing, there are 2 contractions in 10 minutes of period is seen, and this is normal contraction. So looking after the duration of the contraction or gap of the contraction, we can rule out the hyperstimulation in such patients. Next one. Then see the basal heart rate. The baseline heart rate is the average heart rate of the fetus within 10 minutes of window. In 10 minutes of tracing, we have to see the where is the heart rate. Means in this patient, this is the baseline heart rate, which some accelerations are there. Look at the CTG to assess the average heart rate over the last 10 minutes. And in such patient, in such cases, accelerations and decelerations should not be considered, and the basal heart rate at one point is taken in one line. It should be between 110 to 160 beats per minute. Next. C for the fetal tachycardia. Fetal tachycardia is defined as if the heart rate is more than 160 beats per minute, and if the constant tachycardia is seen, then in our mind the following factors should be considered: that there may be a chances of fetal hypoxia, chances of infection if the prolonged leak is there, means like chorioamnionitis, history of hyperthyroidism is there, fetal or maternal anemia, that also shows the tachycardia in fetus, and fetal tachyarrhythmias. Next, please. Then fetal bradycardia. If the fetal heart rate, the baseline heart rate is constantly less than 110 beats per minute, then we call it as a fetal bradycardia. If the baseline heart rate is between 100 to 120, it is commonly seen in the following situation: mostly in post-dated gestation and extreme prematurity also we can see the bradycardia. In positions, fetal positions like occipito-posterior, because there is always many times in occipito-posterior, head compression is there and the bradycardia is also seen. And in transverse lie. If in this constant tracing, in high-risk pregnancy, we take a long tracing, and in such long tracing, if prolonged bradycardia is seen less than 80 beats for more than 3 minutes, it indicates severe hypoxia, and in such situation, immediate action for the early delivery should be taken. And if the prolonged severe bradycardia is seen, the following factors should be ruled out, and we can do some measures like prolonged, if we have to see whether there is a prolonged cord compression, do per vaginal examination to rule out the cord prolapse. Because of epidural or spinal anesthesia, many times we see on the table also there is a fetal bradycardia. In maternal seizures also, fetal bradycardia is seen, and if in precipitated labor, rapid fetal descent is there, and in such cases, because of head compression, the fetal bradycardia is also seen in such situation. Next, please. Then the most important factor is variability. Variability means bit to bit variation. We call it our normal language is bit to bit variation. In this bit to bit variation, if the proper bit to bit variation is there, then it shows the healthy fetus. Baseline variability refers to the variation of fetal heart rate from one beat to the next beat. Variability occurs as a result of interaction between the fetal nervous system, chemoreceptors, baroreceptors, and the cardiac responsiveness. Normal variability indicates an intact neurological system of the fetus. The normal variability is between 2 to 25 beats per minute. This chart is showing the normal variability. To calculate the variability, we have to assess the peaks, and these are the peaks and troughs of the fetal heart and which deviates from this baseline heart rate. Next, please. This variability is very important factor in assessment of fetal well-being. This variability can be categorized as either reassuring, non-reassuring, or abnormal. Reassuring means there is a variation in fetal heart rate from 15 beats to 25 beats per minute up and down regularly. Non-assuring variability means less than variable means fetal heart rate is not fluctuating and it is less than 5 beats per minute between 30 to 50 minutes. If it is for prolonged period, then it is significant. Or the variability is more than 25 beats per minute for 15 to 25 minutes. Abnormal variability means less than 5 beats per minute and the sinusoidal pattern. Next, please. This is the graph showing the reduced variability where the beat to beat variation or the fluctuation is not seen. The most important and the common cause is if the fetus is in sleeping phase. But if the fetus is in sleeping phase, we have to repeat and patient is not in labor, if hyperstimulation is not there, if there are no signs of hypoxia, then in such situations the NST or the CTG is repeated after 2 hours. In such cases, sometimes we ask the patient to eat something or drink some juice or something, and we call them again and repeat the NST. And when we see such repeat NST or CTG, it is always a good it shows good variability. But if the variability is not proper and if it is reduced very much like a straight line or on a same line, then we have to see the fetal acidosis and it is due to hypoxia. And mostly this is with the high risk pregnancy, like if the maternal hypertension is there, diabetes is there, or some obstetric other problems are there. If the fetal tachycardia with less variability, this combination like variability is not there but tachycardia is there, that is also a significant. In some situations, we have to rule out the history. If the mother is on any drugs like opiates, benzodiazepines, alpha methyl dopa, or magnesium sulfate is given. Then in premature cases also less than 28 weeks, I have seen the bradycardia along with the less variability is seen. So NST is mostly not reliable in such situations. And if the fetal congenital heart anomalies are there, in such situation also we see the reduced variability. Next, please. As compared to this variability and these are the accelerations. Accelerations are the abrupt increase in the baseline heart rate of greater than 15 beats for greater than 15 seconds. When generally these are seen when the fetus is moving or kicking. In such situation, good accelerations are seen, and the mother also, we give some instrument in her hand to mark the fetal movement. And if the acceleration are coinciding with the fetal movement, it is absolutely a normal CTG. The presence of acceleration is always a reassuring. Accelerations during intrapartum phase coincides with the uterine contraction and it is a sign of healthy fetus. And if the absence of acceleration is there, then there is some significance and we have to see for the fetal hypoxia or fetal distress in such situation. Next, please. Now the most important part is decelerations. Decelerations are an abrupt decrease in baseline fetal heart rate of greater than 15 beats per minute for greater than 15 seconds. Like accelerations are 15 beats increase in heart rate and decelerations are greater than 15 beats, less than means drop of more than 15 beats per minute and more than 15 seconds. Now in fetal heart physiology, the fetal heart rate is controlled by an autonomic and somatic nervous system. The fetal heart reduces its heart rate to preserve myocardial oxygenation and perfusion. Means the first response of fetus in hypoxia is first to reduce the heart rate to preserve the myocardial oxygenation and perfusion, and this reduction in heart rate is referred to as a decelerations. These decelerations are also of different types. All decelerations are not bad. Few decelerations are okay. Means if they get recovered, they are not that significant. But decelerations like late decelerations are very significant and we have to take some good decision, early decisions in some situations. So these decelerations are early deceleration, variable, late deceleration, prolonged deceleration and sinusoidal patterns. Next, please. Next, ma'am. Next, please. Asha, ma'am. Now we'll see the early decelerations. Early decelerations start when the uterine contraction begins and recover when the uterine contraction stops. So these decelerations means this drop in fetal heart rate up to 15 beats or 16 beats per minute coincide with the peak of the uterine contraction. This is due to the increased fetal intracranial pressure causing increased vagal tone, and so there is a drop in fetal heart rate. These decelerations quickly resolves, means once the contraction goes, again the fetal heart comes up, and these are considered to be physiological and they are not pathological decelerations. Next, please. Now this chart is showing variable decelerations. Variable decelerations means there is a drop in fetal heart rate, but they are not coinciding with the uterine contractions. Variable decelerations means a rapid fall in baseline heart rate with variable recovery phase. Means they are not coinciding with it. They are variable in their duration. The duration may be in some drop may be very short, immediate drop and immediate coming up of fetal heart rate. Some drop may be prolonged. They are variable means they are variable in their dropping heart rate, and recovery is also very fast, and they are seen generally in patients of oligohydramnios. So if such variable decelerations are seen, please see the obstetric means ultrasound report whether there is decrease in Liker. Moderate to severe oligohydramnios generally shows such type of decelerations. Variable decelerations are usually caused by the umbilical cord compression. That's why it is common in oligohydramnios. What happens in these cases? The umbilical vein is often occluded first, causing an acceleration of the fetal heart rate in response. After umbilical vein, the umbilical artery get occluded, which cause subsequent rapid deceleration. Next, please. Means the first umbilical vein get blocked, then umbilical artery, and when the pressure get relieved, on the cord, it is reduced and another acceleration occurs, and then the fetal heart returns to the normal heart rate. The presence of variable deceleration indicates that the fetus is not yet hypoxic and is adapting to the reduced blood flow. So these are the physiological changes occurs in the fetus, means some drop is there and again recovery is seen. So these are the adoption method of the fetus. If variable decelerations present, please, in such cases, if the case of oligohydramnios is there or the patient is lying down in a means supine position, in such situation, we ask our patient to change the position to left lateral position. Because of that, the pressure on the inferior vena cava also get reduced, and in such patient, hydration is also recommended. But if the variable decelerations are present because of oligohydramnios and maybe the chances of cord compression, close monitoring is needed in such patient. Next, please. Now we are coming to the late decelerations. Late decelerations begin at the peak of the uterine contractions and recover after the contraction ends. This type of deceleration indicates there is a insufficient blood flow to the uterus and the placenta. These late decelerations are very significant for the immediate action of delivery. Blood flow to the fetus is significantly reduced, causing fetal hypoxia and acidosis if late decelerations are seen. This is caused by the reduced uteroplacental blood flow. The causes may be a maternal hypotension, preeclampsia, eclampsia, or the most iatrogenic cause is uterine hyperstimulation. Many times we see the labor induction with misoprostol, meso tablet, and that induction is not in our hand. Oxytocin drip we can reduce or we can increase, but once we do the induction with the meso, in such situation many times the uterine hyperstimulation ensues, and so in many cases of induction with meso, meconium stained liquor we get and late deceleration is always seen in such patients. Next, please. In late decelerations, these are the prolonged deceleration. Prolonged deceleration is defined as the deceleration that lasts for more than 2 minutes. If it lasts between 2 to 3 minutes, it is classed as a non-reassuring. And if it is lasting for more than 3 minutes, it is called as the abnormal, because if the fetal heart rate is dropping for such a prolonged period, it is a sign of fetal hypoxia and the immediate delivery is recommended in such patients. Next, please. This is the sinusoidal pattern of the CTG, which is very rarely seen, but if it is seen, it is associated highly with the fetal morbidity and mortality. If such patient, such type of tracing is seen, there are, means we call it as a impending IOD-like situations. This sinusoidal CTG pattern has the following characteristics. It is smooth, regular wave-like pattern, frequency of around 2 to 5 cycles in a minute, stable baseline heart rate around 120 to 160, no beat-to-beat variation is seen. This sinusoidal pattern is usually indicates one or more of the following, like severe fetal hypoxia, severe fetal anemia, or fetal or maternal hemorrhage, like abruption cases. Next, please. And the last O of Dr. C. Bravado is O is the overall assessment. Once all the factor is seen, means the after looking at the baseline heart rate, then contractions, then variability, beat-to-beat variation, acceleration, deceleration, after looking at such tracing for 10 to 20 minutes, we have to do overall assessment of the CTG. And the categorization of CTG is according to fetal heart rate is done as a normal, where the CTG, all the four features fall into reassuring category. Suspicious, where the CTG whose features fall into one of the non-assuring categories and the remainder of the features are reassuring. And pathological means a CTG whose features fall into 2 or more non-reassuring categories or 1 or more abnormal categories. Next, please. So, CTG is described as reassuring, suspicious, or abnormal on the basis of NICE guidelines. Reassuring means if the baseline heart rate is between 110 to 160, variability of the beats more than 5 beats per minute, there are no decelerations and accelerations are present. This is reassuring or normal. Non-reassuring means there may be a fetal bradycardia, means 100 to 109 fetal heart rate or more than 160 to 180, variability less than 5 beats per minute or excessive variability, that is more than 40 beats per minute, and decelerations like or maybe early decelerations, variable decelerations, or single prolonged deceleration up to 3 minutes. So that is also non-reassuring, and we have to make some hurries. We have to monitor such patients closely, give call to anesthetists, pediatrician, and observe such patients. And abnormal CTG is fetal heart rate less than 100 beats per minute or tachycardia more than 180, sinusoidal patterns, variability is less than 5 or more than 25 for more than 90 minutes, and decelerations means atypical variable decelerations are there, late decelerations are there, or a single prolonged deceleration of more than 3 minutes, and such patient should be immediately taken for cesarean section. Next, please. So how the interpretation is done? First see the evaluate the tracing, means first see whether it is a sufficient or not. Only the 10 minutes tracing or sometimes 20 minutes of tracing is not enough. Proper 20 minutes, 30 minutes, or up sometimes in high risk cases 40 minutes of tracing is also required in such cases. After looking at this tracing, see the sonography report of the patient, correlate that report with the patient, whether patient is on any drugs, see the bad obstetric history, see the past history of the patient. That is also very important doing the interpretation, not only in this pregnancy, but we have to correlate with the past pregnancy and past labor history also. Identify baseline fetal heart rate, variability, then whether it is variability is absent, minimal, variable, or moderate, acceleration is there or decelerations are there. Then the contractions, whether the contractions are regular, how is the intensity of the contractions and the duration of contraction, whether there is hyperstimulation or not. Correlate accelerations and decelerations with the uterine contractions and identify the pattern. Determine whether the FHR recording is reassuring, non-reassuring, or ominous. Document interpretation of FHR, clinical conclusion, and plan of care. Next, please. Next, please. Now the management. Now the FIGO fetal heart rate pattern classification. FIGO pattern is used for this management of looking at the CTG. We can manage such patient. If normal is there, then the fetal health is good and we can continue with if the patient is in labor. If there any suspicion is there, means as I have discussed, if it is non-assuring, then continuous observation is required, and additional test, additional history, assessment, continuous tracing is required in such patient. And the plan should be kept in mind कि if any problems comes, the immediate delivery should be done in such patient, and if it is pathological, then intervention of labor is must and immediate delivery is required by either by the instrumental delivery or by cesarean section. Then if suspicious, equivocal, or non-assurance, continuous fetal monitoring is required. Amniotomy is performed to see whether any meconium stem liquor is there. Fetal skull blood sampling is done, but not done in our cases, our situation much. Next, please. If non-assuring NST or CTG is seen, if the heart rate is non-assuring, then discontinuation of any labor stimulating agent is done. Means if the oxytocin drip is going on, then the drip is stopped, plain drip, or it is given to the patient, left lateral position is given, hydration is done, and after some time, then again the CTG or NST is repeated. At the same time, cervical examination is done to rule out whether there is any umbilical cord prolapse is there, what is the cervical dilatation, and what is the descent of head. Then according to that, whether to continue the normal, means to allow the patient to go for normal labor or some intervention is required, that decision is taken. As I have said, this changing maternal position is important. Monitoring of BP is important. Whether there is any evidence of hypotension, especially in cases of regional anesthesia. If there is any present with regional, then in such situation, ephedrine or phenylephrine may be warranted. Next, please. If the uterine hyperstimulation is there, then as I have said, stop the augmenting agent or oxytocin drip. Then presence of abnormal, if presence of abnormal FHR pattern is there, non-secondary to oxidation infusion, then tocolysis is given. In cases of suspected or confirmed acute fetal compromise, delivery should be done as soon as possible depending on the maternal factors. If any other factor is associated with it, means moderate or severe PIH, mother is diabetic or asthmatic, any other complication is there, then the delivery should be planned immediately. According to protocol, delivery should be done. If it is non-assuring, bad NST, late decelerations are repeated, prolonged decelerations are there, then in such situation, delivery should be done within 30 minutes. One more point is whether to give maternal facial oxygen therapy or not. One theory is that if prolonged use of oxygen is given, it may be harmful to the fetus. There is no direct evidence or there is no confirmed evidence evaluating which shows benefits of facial oxygen. Though we people give during anesthesia, I mean during cesarean section also, if there is drop in fetal heart rate, we give oxygen, but this is controversial. Next, please. As I have said, if abnormal or pathological CTG is there, amniotomy is performed. Fetal scar blood pH, if meconium stain liquor is there, but not much practice in our routine practice. Immediate decision of delivery or cesarean in clinical indication like insufficient cervical dilatation, if CPD is there, or any other maternal indication is there. Next, please. In special situations like asphyxiated infants or any other bad obstetric history or history of IUD or anything is there, and in current pregnancy or some high risk factors are there, early delivery is planned in such situation either by the instrumental or by cesarean section. Next, please. These are the special situations like placental abruption, where uterine irritability is shown by frequent contractions of low amplitude. So, initial tachycardia is seen, then decelerations, no accelerations are seen, there is no variability is seen, and then it is followed by a bradycardia. And we have to see this is placental abruption is not only diagnosed on CTG, it is totally a clinical judgment. We have to see the uterine contraction, see for the PV bleeding, fetal heart rate, and accordingly we have to proceed for the treatment. Next, please. There are some situations like abnormality in fetus and how the CTG shows in such situation. Like if CNS abnormality is there, baseline variability may be there, low baseline heart rate is seen, and there is discrepancy between CTG and biophysical profile. If cases of heart block is there, then persistent bradycardia, then no response to the stimulation. When we give stimulation to the fetus, there is no response to the fetus, there is no variability or accelerations are not seen. Heart block may be due to dying fetus and constant decelerations, tachycardia, or lack of accelerations or variability. Any of these type of fetus are seen in such high risk situation. Next, please. This is all we discussed, means if the decelerations, early decelerations are seen in second stage, nothing to be done. Late decelerations are there, and if the hypercontractibility is there, stop oxytocin and left lateral position. This is all a chart. Next, please. This is all discussed. Next, please. This is abnormal or pathological tracing. If baseline heart rate is more than 150 beats per minute with repeated variable deceleration, silent pattern for more than 90 minutes. If complicated variable decelerations are there, prolonged bradycardia of more than 10 minutes, these are all pathological or abnormal tracing, and in such abnormal or sinusoidal pattern, repeated late deceleration, prolonged late deceleration, all these are abnormal or pathological tracing, and decision of immediate delivery should be taken in such situations. Next, please. Though we not practice in our situation internal cardiotocography, in internal cardiotocography, we use electronic transducer connected directly to the fetal scalp through the cervical opening and is connected to the monitor. Internal monitoring provides more accurate as compared to the external, because many external factors may affect the CTG recording, but internal is more accurate. And if in foreign countries or abroad, if the external monitoring is suspicious, then they proceed for the internal cardiotocography. Internal monitoring may be used when external monitoring of fetal heart rate is inadequate, but there are some criteria needed for internal cardiotocography. Next, please. Next, madam. Next, please. This is for this internal monitoring. The cervical dilatation should be minimum 2 centimeter. Amniotic membranes must be ruptured, and the most important criteria is presentation should be cephalic and presenting the part down against the cervix. These are the must things, and then only we can do the internal monitoring, but we are not practicing in our situation the internal monitoring. Previous slide, please. Previous slide. Previous one, please, madam. Previous one. This is external or indirect monitoring, but this we have done. Next, please. Next. So in conclusion, we have seen all the parts of CTG, means how to do the external monitoring, internal monitoring. What are the must part, means what are the things to be seen in CTG, like basal heart rate, variability, accelerations, decelerations, late decelerations, and accordingly we have to take the decision of delivery, means whether to normal delivery or cesarean section. But current evidence does not support the use of admission CTG in low risk pregnancy, and so it is not recommended. According to Cochrane review from February 2017 journal, CTG was associated with fewer neonatal seizures, but no clear differences in incidence of infant mortality and cerebral palsy. Continuous CTG monitoring, it is associated with higher rate of cesarean section and instrumental deliveries. It is seen that if we monitor the labor with CTG, there are little bit higher chances of cesarean section because of false positive results. But what I think is, in this era of medico-legal cases, CTG tracing is must, and we must have some tracings of CTG with us for labor monitoring, and we can explain this to the patient time to time. What I do in my practice, generally I do the CTG tracing and always show it to the patient so that the patient understands well, and it is always easy for us to explain to the patient and relatives. Thank you so much. Thank you, MC Patel sir, and the team of Happy Learning for giving me this chance to deliver this talk. Thank you so much.
Thank you, Daily Madam. Very nice and elaborative talk on CTG. As you said, in this era of medical legal practice, we should have some black and white thing in our hand for taking the decisions.
Yes.
Because nowadays, research, and we should have a CPG to claim that we are doing the things according to the law. So it's a very nice lecture. Everything is explained. Early deceleration, variable decelerations, then what is the normal CPG, what are the abnormal CPGs. Everything is explained very nicely and thoroughly. So I would like to thank Daila Madam. Thank you very much the team for organizing such a nice series for our encouragement and well-being in our practice. Thank you very much.
Thank you very much.
Thank you very much, Dole Madam. It was a very nice lecture, and you have really talked about the practical applications of CTG. Thank you.
Nice lecture, Dr. Daule. Very informative and very important.
Thank you
also.
so much. I'm just getting my presentation together. So just a minute before I start. Meanwhile, I would request the chairpersons to have any questions.
If there is no question, we can go ahead.
Yes, sir. Just starting. Just a second.
Okay.
Dr. Vikas has actually just sent his CV.
Ma'am, shall I share the presentation because I have it ready?
Yeah, I just got it ready. No issues. Just got it ready. Okay. Just a second. There. Ready. So now, thank you so much, ma'am, for that excellent presentation. It was very elaborate. And now I would like to share the screen and start the webinar. Panel, the reverse panel. So welcome to this panel on legal issues and labor. We have already seen how useful a CTG or how not useful a CTG can be in a case of labor. I would like to introduce the expert for this panel, Dr. M.C. Patel, sir. He needs no introduction on this platform, but still, it's a great pleasure to introduce sir. Sir was the Vice President of FOXI 2018, Organizing Secretary of AICOG 2017, Chairperson Ethics and Medico-Legal Committee FOXI 2011 to 13, Honorary Secretary SOGOG 2022 to 24. He's organized n number of conferences. He is a member of many prestigious platforms, including the National Inspection and Monitoring Committee, PNDT. More than anything else, with all his presidentship, honorary membership, and many things, he basically is one person who has continued to be helpful to each and every FOXian for the last 15 years. For the last 21 years, he's been going to the Northeast and working for underprivileged women, holding a camp, health camp for a week every year, again for 21 years. And this webinar is 187. So consistency, dependability, approachability, all that together is MC Patel, sir. So welcome, sir. Thank you for having this webinar.
Thank you.
And now I would like to first share a video about sir. That's me. I've already been introduced.
शुभं करोतु कल्याणं आरोग्यं सुखसंपदम्.
Respected seniors and dear colleagues, serving FOXi for years together.
Ma'am, I'm there. You know, I personally, the surgery is beautiful, but
झालं का बरं होतं कलेक्शन 34 ठीक आहे मंगळवारच्या म्हणजे बरंच बरं आहे दोन्ही धरून का
So now we start with the panel. We have all our panelists here. And before we actually start the panel, I would request everyone, please endorse the candidature of MC Patel, sir, for FOXi President election year 2024. And me, please kindly nominate and support for FOXi Food, Drug and Medico-Surgical Committee election year 2024. You will have nominations in your hand next month.
So in month of May, there will be communication from FOXi to each society for inviting nomination for different posts. So at that time, all the president and secretary who are here have to nominate my candidature for post of president FOXi and Dr. Asha Jain's candidature for chairperson Food and Medico-Surgical Equipment Committee FOXi.
Thank you,
Election
sir.
would be in month of August. So then you will have to vote, and as far as voting is concerned, for office bearers, so that is for me, all the FOXian friends will vote, and for Asha, all the society, that means president and secretary, will vote for chairpersonship.
Thank you, sir. So we start the session.
Oh yes,
And
welcome.
as usual, I ask my first question to you. that legal problems in labor, is it worth discussing? That is my first
Yes.
question.
Yes. If we go with a statistic from USA, 78% gynecologists are sued in their lifetime at least once, and 37% gynecologists are sued for more than 3 times in their lifetimes. And all these cases mostly related to obstetric practice. If we go with Indian statistic, then medico-legal litigations are increasing in number constantly and steadily, and we gynecologists rank first. So as far as medico-legal consequences are concerned, gynecologists are in driving seat, and most of the cases are related to our obstetric practice. Of course, there are few cases related to gynec practice, but majority of the cases are related to obstetric practice, and usually something goes wrong during pregnancy or during labor or during surgery or after delivery, after surgery. So these are some areas as far as our OBGYN practice is concerned, and that is why it is very much worth discussing. And as far as delivery of baby is concerned, if baby delivers compromised or having some physical problems or residual effects rather, then these are the situations which are potential as far as litigation part is concerned. Yes, next.
So, sir, next we have Dr. Mayuri Kelkar, ma'am. She is the past secretary of Nasik Obstetric Gynec Society. And you can see she loves singing.
Very good.
She didn't send me a video though. So over to you, Mayuri, ma'am.
Hello, am I audible?
Yes.
Yes, ma'am. Yes.
So, this was like an eye opener that pregnancy, which is such an
You are not audible, Dr. Mayuri.
Dr.
Hello.
Mayuri, we cannot hear you. Dr. Mayuri,
Something went wrong with her communication system.
you were speaking. We could hear you in the beginning and then we stopped hearing you. Please remove those AirPods.
And please unmute. You are muted now.
Can't
Hello?
hear you. Can't hear you. Please remove the AirPods. Remove them totally. Ma'am, now try speaking. Mayuri, ma'am, now try speaking.
Hello, am I
Yes,
audible?
now we can hear you.
Yeah, so this was really an eye opener that pregnancy, which is such a happy event in patient's life, can lead to such litigations for a gynac. So just I wanted to know about any case related to this, and what are the areas of litigation, like in which scenarios you get litigations, in which part of the pregnancy or whatever, and which are the assisted obstetric situations which may lead to litigations.
So, as far as our obstetric practice is concerned, just I mentioned prior also, we gynecologists rank first as far as litigation part is concerned, because usually we deal with young patients. Of course, there are aged patients also in few of the condition, but usually as far as our obstetric practice is concerned, they are young patients. Usually they come on foot. Of course, in few of the condition, patient can be brought in stretcher or in ambulance, but usually they come on foot. Usually they are book patient. Of course, in few of the condition, they could be emergency patient also. And relative and patient consider pregnancy as a physiological procedure and not as a pathological one. and expectation on part of patient as well as relative is much higher. They are not ready to accept any complication related to pregnancy or related to delivery. So these are that is why it is very common as far as pregnancy or labor related litigations are concerned. As far as areas of litigation is concerned, there are common allegations in this type of situation. It was delayed in diagnosis, delayed in sending for investigation, delayed in starting treatment, wrong diagnosis, no proper concern, infrastructure issues, staff not qualified, investigations were not made in time, complications related to labor, or during surgery like cesarean section, some complications or infection or complication of this anesthesia. So these are some problems, and outcome of baby. If baby comes compromised, meconium strain, etc., we have to ship in an ICU backup. And naturally, in this situation, expense will be much higher. So one more allegation is exorbitant expense against unexpected result. So these are some areas as far as this litigations part is concerned. And as far as assisted obstetric situations are concerned, of course, nowadays external cephalic version, our Foxian friends are dealing with, I do not know, but these are some areas, external cephalic version, internal Pudelic version, or any other procedure we go in during labor or during pregnancy or during labor also, vacuum delivery, forceps delivery, and any injury related to that, to the fetus or some perineal tear, particularly complete perineal tear, or we call it complete perineal tear leading to incontinence of defecation, etc. These are some areas as far as litigation part is concerned, and very major area is hemorrhage. So antenatal or postpartum hemorrhage is much more known in this type of situation as far as litigations are concerned. Yes.
Thank you so much, sir.
Thank you. Yes, next. Asa, you are muted. Please unmute.
Yeah, so thank you, sir. So we have Dr. Sangeeta Wagh, ma'am, who is the current president of Nasik Society, and she loves yoga, music, gardening, and you can see her pets. So what a background to live in. So over to you, Dr. Sangeeta.
Madam, she had to leave for a surgery, emergency surgery.
Sir,
So
do you mind taking it?
sure.
Dr. Anjali?
Yes, thank you so much. Am I audible to everyone?
Yes, you're audible.
Yes, you are audible.
Yes, thank you, Dr. Patel, sir, and Dr. Asha Jain, ma'am. So this is baby Ramya versus Dr. Aruna Reddy, 1995, CTJ 367 AP. So what were the facts of the case? It was a forceps delivery, delivered baby of 4.5 kilo vaginally, and the baby developed certain problems. So case was filed. The defense on part of the doctor was that it was a complicated case, and so patient refused C-section. If I'm not able to see it. The inference held by the court was that she was admitted at 6 a.m. Delivery started at 4 p.m. No investigations or sonography. No evidence that consent was refused. Allowed rupees 1.75 lakh. So where the things went wrong for that case? If you could
So
elaborate.
in this case, baby was 4.5 kg and it was vaginal delivery. So whenever we are dealing with such type of cases with big baby, 4.5 kg, and whenever we are going to deliver it vaginally, proper counseling with patient and patient party is very much required. with all possible outcome and probable complications or prognosis. And if at all it is required to go for cesarean section also, it should also be mentioned, because in this case, when they refuse for cesarean section also, they didn't go for negative consent. So if it is indicated to go for cesarean section, and if we have advised, if patient is not ready to sign consent paper, then we have to document it that it is required and patient is not willing or patient is not ready to give consent. So this is very important part. And second, what was the allegation? One more allegation. Yes, the patient was admitted at 6 a.m. and delivery started at 4 p.m. So it was inference held by the court that no investigation or sonography or no evidence of consent was refused. So in this situation, if at all any sign of fetal asphyxia or so, and if we advise any investigation, just like CTG, very nicely covered by Dr. Josna madam. So if we have CTG tracing, then these are the evidences that we have taken utmost care of that very patient. And if there is a deviation as far as CTG tracing is concerned, just like lead deceleration or so, and at that time we have to advise patient to interrupt with going for normal delivery, and we have to switch over to another mode of delivery. So if we have counseled properly, if we have taken proper consent, then it is always better and it becomes good defense in our favor. Yes, next.
Thank you, sir. So, Dr. Anjali, next is your case. So, Dr. Anjali is the secretary of Nasik Society now. She has an experience of 20 years, though you're looking really very young. So, congratulations on that. She does various PCOS awareness programs in schools, colleges, companies, loves watching movie and relaxing. So, over to you, Dr. Anjali.
Thank you so much. So this was a case, Neena Gupta versus Deep Nursing Home, 1996, Chandigarh. The facts of the case were that it was a forceps delivery, which resulted in a utero-vesical fistula. Defense on part of the doctor was that it occurred during the process. Inference held by the court was that it was liable. So in this case, what were the things that went wrong, sir?
So again, in this case also, it was forceps delivery. So just I mentioned prior also, whenever we are going to have any instrumental delivery, forceps or vacuum or so. So again, we have to counsel patient and patient party very thoroughly that which are the implications of this forceps delivery, which could be the probable complication to mother, complication to baby. With, of course, utero-vesical fistula should be very rare condition, but in this type of situation, many a time, if there is static and there is no progress due to pressure necrosis, it may turn into utero-vesical fistula after 3, 4, 5 days or 1 week or so. So when we are dealing with prolonged labor and when we are going to go for forceps delivery, of course, it could be due to prolonged labor as far as this utero-vesical fistula is concerned. But usually, patient and patient party will believe that it was due to injury due to forceps delivery. So here again, proper counseling is very much required.
Thank you, sir.
Yes.
Thank you, sir. Now we have Dr. Prashant Zende, and he's a consultant obstetrician gynecologist, fertility specialist, practicing for so many years, has passed MBBS in 1990. He's an avid cycling and traveling person. So over to you, Dr. Prashant.
Yes, Prasanth Bhau. You are muted. Please unmute. Prashant, you are muted. Please
Yeah.
unmute.
Yeah.
Yes.
Now,
Welcome.
am I audible
Welcome.
now?
Oh, yes. Welcome.
Now, my question is, please discuss birth injuries and litigation. Which injuries are most likely to cause?
So, as far as birth injuries are concerned, either it could be with mother or it could be with baby, or
Baby.
it could be with both also in few of the
Yeah.
conditions. But usually, obstetric anal sphincter injury is the area as far as birth injury is concerned, which may lead to litigation. Because in any birth injury, when we have to deal with that injury or to deal with that very complication, and stay of patient becomes lengthier in the hospital, there is some expense, or in few of the cases she may go with some physical disability, and then it becomes a litigation part. As far as other injuries are concerned, vulval or vaginal lacerations, vulval hematoma, or cervical tear, or paraurethral or urethral tear, then rupture of uterus, whether it is repairable or non-repairable, and in few of the condition we have to go for obstetric hysterectomy also. So these are the areas as far as birth injuries are concerned. And as far injuries to the fetus is concerned, then fetal asphyxia is a very common condition where we may end up into litigation. But as far as injury part is concerned, iphel hematoma, fracture of bone, clavicle, or long bone or so, Earth palsy.
Yeah.
So these are some injuries related to fetus also. And of course, it is very rare, but during cesarean section, if there is any cut due to our knife or so on body part of fetus, then it could be also one of the area for litigation. And very rarely, perinatal death. Perinatal death of fetus, it is also one area as far as litigation is concerned.
Can you add one more thing, sir?
Pardon?
Can I add a few things?
Oh yes, oh yes, oh yes.
As far as if it is a high risk pregnancy or if it is FGR baby, cerebral palsy is most common that
Yes, yes. So Earth palsy and cerebral palsy also, because at that particular time of point of time, at the time of delivery, even a pediatrician may not diagnose, but after some time, after 1 week or after 1 month or so, whenever baby turns to be CP or any other problem, then they will usually correlate it with the process of delivery. So in this situation, we are many a times alleged that it was carelessness on part of doctor at the time of conducting the delivery, which led to this CP also.
And one has to document everything. It was not antepartum. It was antepartum. It is not intrapartum. One has to have CTG or fetal monitoring
this is
records.
good defense, and in few of the cases, court has also considered those, whether it was antenatal,
Or
whether
antepartum.
it was during
Intrapartum.
process of labor, or due to some other reason postpartum. So if we can prove, and in all these cases, usually end result is not taken into consideration always in court of law.
And
They
one
consider
must not.
our efforts not to have any complication and to have safe delivery on both part, maternal as well as fetal. So this is expected from law in this type of situation.
And one should not use birth injuries as a label. Pediatrician should not write as a birth asphyxia as a loose. You should
Yes.
classify as a
So,
HIV, hypoxic ischemic
so
encephalopathy.
here I will have one good comment. Whenever neonatologist writes his or her note, we have to explain him that whatever happened, of course you can narrate, but there should not be any word. It may correlate that it was negligence on part of obstetrician also. So we should be very careful as far as our notes are concerned. Obstetrician notes as well as neonatologist notes.
One may classify as hypoxic ischemic encephalopathy, HIE.
Yes, yes.
Excuse me, sir.
In this
Excuse
type
me,
of
sir.
situation, yes.
We will have to take the questions at the end, so we have a lot of panelists waiting. Very, very sorry, sir.
Okay, no issue, no issue.
So Dr. Yashwant, sir, are you there?
Yashwant Pawar, sir.
He was not very well, sir. He likes farming, and I would request anybody to please take
Anybody from Jalgaon can take, no issue. There 40 gaon.
Hello,
Yes.
this is
Yes, sir.
Dr. Pawar. Can I take Dr.
Oh
Yashwant's
yes,
Yes, sir.
oh
question?
yes,
Yes, sir.
oh yes.
Please.
Welcome, sir.
Okay. Patel sir, there is a question about how can we define negligence? And then what are the types of negligence that an obstetrician can come across in his day-to-day practice?
Yes. So, in our MBBS curriculum in forensic medicine, we were taught 2 words: act of omission and act of commission. So, act of omission means not to do something which a reasonable, prudent doctor would do. Say, for example, if injection penicillin is to be given, any prudent doctor will go for negative test dose, and if it is negative, then only he will go with full dose. So it is act of omission. So in our obstetric practice, if we omit certain things which any prudent obstetrician would not, then it becomes a case of negligence. As far as act of commission is concerned, that means doing something which usual prudent doctor would not do in that very given situation. Say, for example, if it is a planned cesarean section and you have instructed patient to come empty stomach and patient has come up with full stomach, it is not an emergency, it is planned surgery, and surgery was decided in general anesthesia. So to give general anesthesia on full stomach in elective surgery is an act of commission. So as far as negligence part is concerned, this is the situation. As far as type of negligence is concerned, usually whenever any patient enters in our clinic, it becomes a contract or implied contract between patient and ourselves. We offer our expert services and patient pays for that or patient promises to pay for that. So it becomes a contract, and there are 4 ingredients to prove negligence. Say, for example, legal duty. So as soon as we accept any patient to treat, our legal duty starts from that point of time. Breach of that duty. So if we do not deliver our services as per standard medical norms or as per expected, then it becomes a breach of that legal duty. And due to that breach of legal duty, damage occurred to the patient. So if patient has suffered any damage, then this is 3rd ingredient for negligence, and very important ingredient. Action of doctor should be proximate and direct to cause that very damage to the patient. So if these 4 gradients are there, if 4 gradients are proved in court of law, then only it will be considered as a case of negligence. Yes, next. Yes, Mandar, welcome. Yes, Asha madam.
Hello.
Yes, welcome.
Yes, sir.
Asha madam, would you like to introduce Mandar?
No
Yes,
problem.
sir. Yes, sir. So he is the immediate past secretary of Chhattisgarh Society. He has a lot of research on unexplained intrapartum fetal distress, HIV seroprevalence in antenatal attendees, round ligament varicosity. I don't know what kind of an eye you have, Dr. Mandar. You're looking at everyday things in a new way. So obstetric, epidural anesthesia, analgesia and nulliparous, accuracy and reliability of pallor for detecting anemia. So great. Welcome, sir, and over to you.
Thank you, ma'am. Yeah. So what I was interested in, as such, labor is a very routine phenomena, But with that thing, sir, please explain about what is the importance of consent, as well as whether consent is necessary in case of normal labor also.
So as far as consent is concerned, naturally it is very important part of our documentation, because consent is not mere piece of paper where patient or patient party has to sign. Because in very famous case of C. Jaipal Reddy
Yes,
versus
sir.
Padmini Velluri, National
Hello.
Commission has very specifically mentioned that it is important document of your counseling, important document of your communication. So whatever you counsel, whatever you communicate to the patient and patient party, each and every point should be mentioned in that consent paper. And after understanding everything in a better fashion, patient and patient party will have to sign. So as such, it is an important part of our documentation. And as far as consent for normal labor is concerned, of course, it is not tradition in our country, but if at all any normal labor or patient going in normal labor and into complete perineal tear, and if you have to go for repair, then it becomes very difficult for you to explain at that point of time. But if you have counsel patient in a brief, and if you have taken consent for normal labor, then it becomes good defense in your favor. And you have not to worry for this. You have to simply visit Foxy website. And on Foxy website, Foxy uniform consent is available. We three this medical legal expert, Dr. Dilip Walke from Pune, Dr. Nikhil Datar from Mumbai, and myself, Dr. MC Patel from Ahmedabad, we have prepared 30 different consent. And in those 30 different consent, one consent we have prepared for normal labor also. And now it is available in Marathi also. So if at all anybody is interested, may contact me. I will send soft copy of all those 30 different consent in English as well as in Marathi. Yes, next, Manda.
Yes, sir. So more than consent, I guess records are also that much importance.
Yes,
As
equally
usual,
important.
gynecologists are always gynecologists are busy in managing cases, and their documentation might have left incomplete or something like that. So could you elaborate, sir, on importance of
So
record
as
keeping?
far as record is concerned, record is your mirror of your care taken to that very patient. Whatever you have done for that very patient, you can prove in court of law only by record. Say, for example, if it is an emergency, you have given oxygen, but you have not recorded that oxygen was given. In eye of law, it is as good as oxygen was not given. So thing which is not documented is considered in court of law thing not done. So records are always at your rescue as far as any litigation part is concerned. So whatever we have done for that very patient, whichever investigation we have advised during antenatal period, during peripartum phase, and if we have involved our other professional colleague to deal with certain situation, then we have to have note from that colleague also, seen by Dr. So-and-so, his or her findings, whatever advice he has given, or any investigation or as far as treatment part is concerned. So each and everything should be well recorded. And if you submit all those record of your treatment given to that very patient, and if we can prove that treatment was as per standard protocol, standard guidelines, standard medical norms, then it becomes good defense in our favor whenever we are facing litigation. Yes, next.
And finally, discharge card, sir. What is the importance of discharge card?
Again, discharge card is also mirror of our treatment part. So at the time of discharge, naturally we will mention everything in detail about patient name, age, address, provisional diagnosis, final diagnosis, and investigation which we advise with brief summary, and treatment we advise. But very important part is advice at the time of discharge. Say, for example, medicine to be taken, any exercise, follow-up treatment, diet to be taken. And a very important part is references. If at all we have to refer that very patient or baby to another specialist for some given region, then it should also be mentioned in discharge card. I would like to mention one very interesting case which happened in state of Tamil Nadu. It was premature delivery. Baby was admitted in NICU, and in due course, baby was discharged from NICU. But at the time of admission and even at the time of discharge, people from NICU, neonatologists, never advise patients' relative to have an opinion from ophthalmologist to rule out retinopathy due to prematurity. And in that very case, baby went blind. Case was filed and case was decided in favor of patient and patient party, and compensation of 1.8 crore was awarded to the patient. Of course, it happened in government hospital of Tamil Nadu. So 1.73 crore was given by government of Tamil Nadu, and rest of the amount by neonatologists. Luckily, in this case, obstetricians were not made party. So this is very important part as far as discharge card is concerned. And I would like to mention one thing also as far as record is concerned. Important bill of purchase of oxygen cylinder, purchase of ambu bag like emergency instrument, emergency drugs, etc. Because many a times there could be allegation on part of prosecution that you had no injection of adrenaline or so emergency injection. And one more part, bill of refilling of oxygen cylinder. It is also part of your record, because in one of the cases which happened in state of Gujarat only, allegation on part of patient party was when patient suffered heart attack, oxygen cylinder were empty. And we were saved in court of law only due to bill which we could produce in court of law of refilling of oxygen just one day prior of this incident. So we could prove that all the oxygen cylinder in hospital were full, and no cylinder was empty, and we were saved in that very case. So important bill are also part of your documentation.
Thank you,
Hope
sir.
I have satisfied Mandar.
Yes, sir.
Okay,
So
thank
Dr.
you.
Jitendra was having a pain abdomen. So he
Mhm.
said that I may not be able to join from
Just
Dhule.
take care,
Dhule
Dr.
Obstetric Gynec Society President. So requesting Dr. Shashikant sir, are you there? Would you like to take sir's case?
Yes, I'm very much
Yes.
here, madam.
Yes,
I'm the
welcome.
rock
Welcome.
solid for MC Patel, sir. So
Yes,
you can
thank
put
you.
the question to me, I can pass it on.
Sir, the question is displayed here, sir.
Yes. So, yes, Sasikant.
Dr. Shashikant sir.
Am I audible now?
Oh, yes.
Yes.
Oh, yes, you are audible.
Okay. So patient admitted with the labor pains, she was in good health at the time of admission. No satisfactory progress. LACS was advised. Patient and relatives were reluctant to give consent. Doctor was constrained due to non-cooperation from the patient side and empathetically warned the attendants, including the patient, either to give consent for C-section or to take the patient to any other hospital. After 1 hour, attendant gave consent for LACS, but asking for the guarantee of the mother and baby. Now, what do we do at this situation?
So, this is very usual scenario in our day-to-day obstetric practice. So, whenever you feel that immediate cesarean section is very much needed or necessary or indicated, then naturally we explain to the patient and patient party. And if they are not ready to give consent, because usual excuse is her husband is not present, we have informed him, he is coming, and once he comes, he will give consent. So, in this situation, here comes role of negative consent. So we have to take signature of patient and patient party, whosoever is available with him, as a witness that it was explained to us that immediate cesarean section is very much needed, but we are waiting for relative to come, we are not giving consent. And if any complications happens due to this, then doctor will not be held responsible. But in this situation, many a time, we observe that they are not ready to give negative consent also. So in this situation, we can have a signature of any co-patient or any visitor of hospital that it was explained to the patient and patient party before us, but patient and patient party didn't go with consent. So if we go like this, it becomes good defense in our favor.
Okay, thank you very much.
At the time of explaining, we can explain that also. After 1 hour or so, after some time, if at all you give consent, and if you have, I have to very quickly go for cesarean section, but I cannot give you any assurance because precious time will be wasted and there is some goes wrong with fetus, then it will be difficult for me also to manage the situation. So this should also be explained. Yes. Next.
It's the same question, Dr. Bawal.
Yes,
this has to continue now.
Yes, Sasikant Bhav.
Am I audible?
Oh, yes, you are audible.
Good. Now, sir, another situation. In this case, the LACS was performed. Asphyxiated baby with very low Apgar score was delivered. Baby had convulsions also, and after some time, it intubated and shifted to NICU. Now, attendants now blaming the doctor, saying that number one, that you gave us a false source of normal delivery. Number two, wrong medications were given. Number three, fetal heart was not checked during the labor. And another one was like one injection was administered, which stopped the pain for some time and then created a situation such the complainant was compelled to give consent for lower segment cesarean section. And then how do we protect oneself in this case of litigation?
Yes. So this is very usual scenario that false hope of normal delivery was given. So again comes role of consent. So we have prepared consent for normal labor also, and it is available on Foxy website. So in that very consent, we have mentioned everything as far as what is normal labor, what could be the possibility of intervention that is instrumental or operative, and we have mentioned everything in that. See, as far as a wrong medication is concerned, so we can prove that whatever we did or whatever treatment we gave, it was as per standard medical norms or as per standard protocols or guidelines. So if we can prove it by record, and this type of allegation doesn't stand in court of law in usual course. As far as fetal heart was not checked, this is also we can prove it by our record. If we have gone with partogram, if we have gone with CTG, then we can prove that we have checked that very patient at very regular interval. As far as this allegation that some injection was given and there was a stoppage of pain and created situation, these are some vague allegation and it cannot be proved in court of law. And as far as burden of proof is concerned, it is on shoulder of prosecution. So whichever allegation they put, they should prove it in court of law. So these are this type of allegation. These are of course usual allegation, but doesn't stand in court of law. Yes, next.
Thank you, sir. So now we have Dr. Vishal Patil. He just messaged that there is some surgery and it's an emergency. He does lawn tennis and traveling. So, Dr. Vishal, are you here? No, he told me he had to go.
No issue. Anybody from Jadgaon? Priti, is she there?
Dhule.
Shall we go ahead, sir? I can take this question.
Yes, we can.
Yes. Now, this is on behalf of Dr. Vishal. A baby saved, but then there was then the baby developed cerebral palsy. Now the attendants, they filed a case against the doctor, how to deal with such kind of a situation and how to counsel these such attendants also, and how to handle the litigation. In the same, it is a continuation of the same case.
Yes. So we Mandar and myself were discussing the situation as far as cerebral palsy part is concerned. When there is birth asphyxia and when we have not taken action well in time, then it could be allegation that we didn't go with immediate intervention and it went to asphyxiate baby and ultimately it ended into cerebral palsy. So in this particular case, consent was not given at the time when it was very much needed and it was indicated to go for cesarean section. So in this case, role of negative consent, again, I mentioned prior also. So it becomes good defense, because whatever you advise to the patient and patient party, and if they do not follow your instruction, it becomes contributory negligence on part of patient and patient party. So it becomes good defense. As far as cerebral palsy is concerned, whether it was due to some antenatal region, whether it was due to a region developed during process of labor, or it was after delivery. So if we can prove all this, then we could be out of problem in this type of situation.
Thank you, sir. Today evening,
Thank you very much.
a lot of our panelists are having emergencies. So Bansi Shinde sir also sent me a message that he is in an emergency.
No problem, madam. You can share the question. We can go ahead.
It's there.
Or
It's there, sir.
any other person from Ahmednagar also can do, or other Shashikant is there. Any person from Ahmednagar?
May I know who has Samsung written? I can't see the face and correct name is not there.
Oh. Ganorkar madam is there, madam.
No, she is our chief guest, sir.
We will have expert comment from Ganorkar madam at the end.
No. I can take the question if you want me instead of.
Oh yes, no issue. Our pleasure, madam.
Okay, this is a 32-year-old primey. I am audible, right?
Yes, well audible.
A 32-year-old primey. She was full term and was admitted for labor pains. There was no significant medical past history, and ARM was done and the LICA was clear. Patient had sudden cardiac arrest while in labor and was pulseless, and BP was not recordable and CPR was started. Amniotic fluid embolism was suspected. The patient was intubated, started on positive pressure respiration immediately, and the patient showed signs of a partial revival. What should be done? Should an LSAS be done immediately as the fetal heart was present, or the patient should be shifted to ICU and to any other higher centers?
Very interesting situation. Of course, it is rare to face in labor room, but it may happen. As far as amniotic fluid embolism is concerned, there are few cases decided in Supreme Court also. And one of our Foxian friend from Ghaziabad, she faced this situation. And in that very case, case was lost in lower court, in high court, and ultimately appeal was preferred in Supreme Court. And in that very appeal, we 3 medical legal experts were there to guide our Foxian friend. And we could convince court by standard textbook references, textbook of Williams, etc., what is amniotic fluid embolism, and in that very situation, what gynecologist is supposed to do. Because we have to rule out one by one certain condition, and ultimately diagnosis come as a amniotic fluid embolism. We have to resuscitate patient, and we know that amniotic fluid embolism, of course, it is rare, but is having high mortality rate, and it is accepted in court of law also. In all these 3 cases which were decided in Supreme Court, where result win in favor of doctors only. So in this type of situation, how we represent our case in court of law is very much important. What we did to save life of patient is very much important. As far as this part is concerned, what should be done, and should lower segment cesarean be done immediately as fetal heart was present? So as far as guideline in sudden obstetric collapse is concerned, perimortem cesarean section has its own role, but it is very difficult decision to take for any gynecologist. And in this situation, no need to shift patient in even OT. If you are dealing with that patient in labor room, then you have to straightway go for cesarean section in a labor room only. No need to go for any sepsis part, that is this cleaning and wrapping, etc. And it should be very quick, because if at all you can deliver baby within 3 to 4 minutes or maximum 5 minutes, then only there could be some chances of survival of baby if pregnancy is more than 24 weeks or so. Because in this situation, if we deliver baby immediately, then it becomes favorable as far as resuscitation part is concerned. But at the same time, when we are dealing with this delivery, resuscitation should be continued by other assistants also. But in this situation, it is all likely that there could be allegation on part of relative and case could be filed. So proper documentation after this incident is very much required. Of course, we have no time to call relative or to go explain that we are doing this. But if at all it is possible, then at the time of doing all these things, one relative can be called inside and we can very quickly explain at the time of doing this. We have not to explain and then we have to go with peripartum, perimortem cesarean section also. But if we have explained that this has happened and patient is almost no more, and whatever we are doing or we are trying to save life of patient. So if we have explained this, it could be little defense in our favor in court of law when we are facing this situation.
Yeah, thank you, Dr. Patel. When I asked this question,
Oh,
I
yes.
was interested because we had
Oh,
a
yes.
similar case
Yes.
some years back. The patient had had a normal delivery. We had just finished suturing the episiotomy and she complained of breathlessness. She
Yes.
collapsed, she arrested. We could do a CPR. We revived her. The anesthetist came, intubated. We shifted to a higher center, but unfortunately, after 2 days, we lost the patient. So there was a lot of inquiry, but luckily for us, the corporation, the civil hospital, everyone, since maybe we had our documentation, but even the postmortem did not reveal anything, and they said yes, it could be amniotic fluid embolism, which could just happen suddenly to anyone.
But we have to stamp our diagnosis by clinical observation only, because just after delivery, sudden breathlessness or cardiac arrest, the possibility will come of amniotic fluid embolism. And we can prove it by standard textbook references also.
Correct.
We can also prove it by allowing or requesting court to allow expert witness in our favor, because in this type of situation, court is pleased to allow expert witness also. And if any expert witness of our category, say for example, we are having experience of some 15-20 years in obstetric, and same person with same experience gives our expert comments that in this situation, this is the only way to deal with patient. And if this case would have been to me, I would have done the same thing. Then it becomes good defense in our favor. And in many of the cases.
Excuse me, sir.
Yes.
Excuse me, Patel sir. Dr. C.D.
Yes.
Mishra sir has joined in. I had
Yes,
asked him that if you
welcome,
are
sir,
free, you
welcome.
can join later.
Welcome,
So,
sir. Welcome.
Mishra sir, would you like to say a few words? We have 4 panel questions to go.
Yes, yes. Blessing from C.D. Mishra, sir.
Now he isn't saying anything, sir. So we go ahead.
Yes.
We go ahead. We have 4 more questions, sir. Then you can take the general questions.
Oh yes. Oh yes. No issue. No issue.
So we have Dr. Preeti Poghe with us. She runs MRCOG courses. She has trained more than 500 doctors over the whole world. She does a lot of cultural activities, dancing, anchoring, along with all her academic achievements. So over to you, Dr. Preeti from Jalgaon.
Welcome, Preeti.
Hello, sir.
Yes,
Good evening,
welcome.
everyone,
Good
and
evening.
thank you so much for considering me amongst all the stalwarts. It's really an honor for me to be here. So I have 2 parts to my question. So one is this has happened in one of my friend's hospital only, that this patient had come and the patient immediately died. Like the patient came with pain in labor and the patient died immediately even before seeing the patient. So before
Dr.
attending
Preeti, this is a continuation of the situation previous. Okay.
No issue. But
Okay. Now you
continue.
can just go ahead.
So what like how to handle the case if the patient immediately expires, like exactly same in the case of AFI, like and also there was another case which actually happened in my own corporate setup. So this patient had PPH and she collapsed, and because she was deteriorating, we had to shift her to a tertiary care center, and we attended her, like it was not me, one of my consultants was there, and along with all the with all the things that could be done for her, like taking consent and then counseling the patient's relative, everything, we shifted her to a tertiary care center. And unfortunately we lost the patient immediately after doing an obstetric hysterectomy, and the patient's dead body was brought back again to the hospital, and the nuisance was created, and they were asking for postmortem examination, and there was a media trial again, like they were like all the newspapers had our news, our hospital news. So it was very difficult situation, and
Yes.
me being a part of that, I was really scared. I mean,
So there are two conditions. Shifting patient in this situation to nearby ICU. So if patient is already dead and you have tried your level base as far as resuscitation part is concerned, then no need to shift patient to nearby NICU, ICU, and you have to declare death at your hospital only, because it becomes very difficult in to face situation in court of law, because once patient is already dead, that very hospital will receive dead body, and they will declare that patient was brought dead. So one more question will come: when you shifted patient, whether patient was living or patient was already expired. If it was living, then why you shifted patient without resuscitating patient and making or stabilizing the patient? So it is very difficult in court of law to face the situation. If patient is living, if you have resuscitated well, if patient is stable, then you can very well shift to nearby a tertiary care center for further care. So whatever you do, it should be well documented to prove that which effort you put to save life of patient. Yes. And
yes, I'm about to post
one more area in this. When patient expired on the way and dead body was brought back to that hospital by relative, in this situation, always inform police. Because once police come, situation will be well tackled, and we have to offer postmortem examination on our part only, because to know exact cause of death, it is very much required. And when there is a death of young patient, less than 7 years of marriage life, it is always better to inform police and to go for postmortem examination. Because many times what happens, in-laws a party has brought that very patient, and they are happy with our approach, our treatment, they have nothing to do. But many times maternal part could be in picture, and they may allege some other thing. There was conspiracy between doctor and maternal side. So it is always better to go for postmortem examination in this type of situation.
So what about the FIR? Like if the patient's relative, they lodge an FIR against us, and
yes, they can, any person, not patient or patient, any person can lodge FIR against anybody under CRPC. Any citizen of India is free.
There was a social activist, sir, who did it.
That is why I mentioned under CRPC anybody can. But at the time of first hearing, he or she will have to prove that this FIR, which is lodged against Dr. So-and-so, was correct. So he will have to prove, because burden of proof on his shoulder to prove whether it was prima facie negligence on part of treating doctor which led to death of that very patient. And it is very difficult for any person to prove in court of law negligence against doctor, because we
But
can prove.
In
Yes.
case if there's a mob action, like everybody
Yes.
is there and we are alone, then how to call for help and who all can come for help?
That is why I mentioned in this type of situation, always inform police first. And if you have rush team in your society, then you inform member of rush team. So in this situation, member of rush team, whosoever available, will be at your rescue. I would like to mention very quickly one incident happened in city of Ahmedabad only. We have rush team. Ahmedabad is big city, so we have a rush team in each area. And in one of the area, there was situation, and in this there was mob violence. So that doctor informed 1 or 2 persons of rush team in that very area, and you won't believe within 1 hour 150 gynecologists were there at that very hospital, and situation was well tackled because police was informed and everything was taken care. So in this situation, it is always advisable to inform police and to inform our professional colleague so they can be at our rescue in this type of situation.
Thank you. Thank you so much, sir.
Yes. Yes, Sachin. Yes, Sachin. Is Sachin there? Or anybody from Chalisgaon?
Am I audible?
Oh, yes, welcome.
Sir, you said regarding this first case, you should declare the death. But in a, say, small maternity home or it is very difficult to declare the death.
And that is
Although we know the patient is dead, but if we declare, then all this mishap and nonsense happens. So we have to do something like kuch to bhi kar rahe hai, intubate karo, and then you have to shift, and we have to ask tertiary care people to declare the death, because it is very difficult to declare death at our hospital.
What happens in this situation, once patient is already dead, and if you shift that dead patient to nearby ICU unit to just make a show that we are doing something. So in one of the case, there was comment on part of court, it is easy to face litigation and it is difficult to face charge of forgery, because once you shift dead patient to ICU, there could be many other allegations against you. So not to end up into this situation, it is always better. Of course, it is a difficult situation to declare, but you can have a phone call to your some professional colleague. They should be there. Police should be informed, and then you declare. It is not necessary that you should declare immediately. Even if you have time, then you can very quickly prepare your documents also, whatever treatment you have given at this important point. Not to miss, because many
when
times
patient came brought dead, there was no documents is very
yes, when patient is brought dead, then it is a easy situation to deal with, because in this situation you have to declare that patient was brought dead, because in that very situation you are not at all responsible as far as any treatment part is concerned, because you are not at all treated that very patient. You can try for resuscitation and you can declare it was already dead. In spite of all this, I tried my level best to resuscitate this patient. And in this situation also, you can inform police, because if they insist to give death certificate, and if patient was brought dead, it is difficult for us to give death certificate, because death certificate is not mere certificate that patient so and so was brought to us in a dead condition, because we have to give cause of death also. And when we are not knowing cause of death, what we can mention in that very death certificate. So for that also we have to advise postmortem examination.
Sir,
Death
that is
certificate.
Mishra sir speaking, sir.
Oh yes, welcome sir.
Yeah. Then death certificate is out of question. You can't give death certificate because
Yes.
for maternal mortality there are so many inquiries and you just can't
Yes.
give a death certificate. You have
So that is why also if postmortem examination is advised on our part, it shows that we are very bona fide as far as dealing with the situation is concerned.
Thank you, sir. Sir, should we go forward? We have Dr. Vikas Godhe, sir. He is a laparoscopic surgeon for the last 30 years. His hobbies are playing tennis and photography. He's been president, secretary, whatnot of Nasik Society.
Good evening,
Vikas,
sir.
sir, you are here.
Yes,
Would you
welcome,
please?
Vikas.
Yes, sir. Good evening.
Good evening.
My question to you is that against whom medico-legal complaints can be lodged and where we should lodge these complaints?
Yes. So in one sentence, if I have to answer your first question, again, any medical service provider complaint can be lodged. Doctor, your lower staff, pharmacist, radiologist, sonologist, dental surgeon, against any doctor, service provider, one can lodge complaint. But just I mentioned prior also, burden of proof is on shoulder of complainant to prove that it was medico-legal negligence on part of treating person.
Does this medical indemnity protects us, and the FOXI and the IMA policies are better than the
Yes. So as far as indemnity part is concerned, it's good question, because in era of CPF, one cannot afford to practice without indemnity cover. And as far as coverage on part of FOXI is concerned, so FOXI had a collaboration with ICICI Lombard, and FOXI came up with indemnity cover. And CoverU is the third party. So CoverU is taking care in this type of situation. There are two good points I would like to mention as far as indemnity cover on part of FOXI is concerned. Usually in other insurance company, they do not entertain your untrained staff. If there is something goes wrong with untrained staff, you are vicariously liable, and company will not take any responsibility because your staff was not trained. But in FOXI indemnity cover, it is covered. So FOXI indemnity cover will cover your untrained staff also. One more part, outside court settlement. So other insurance company will not entertain outside court settlement. They will go with fighting the case, and at the end of whichever result comes, they are ready to face. But in FOXI indemnity cover, there is provision of outside court settlement also. If there is a legal opinion that this is difficult case to win, or this is short case to lose, that in this case, one can go with outside court settlement also. So for those 2 points, indemnity coverage on part of FOXI is better.
Thank you, sir. Thank you very much for guidance.
Yes, second question was where complaint can be lodged. So one can lodge complaint if they are interested for money or for compensation, then they can issue complaint in civil court or under CPA. If they are interested to have criminal action, then they can complain in police station or in criminal court. They may lodge complaint in medical council also, in Human Rights Commission also. If it is against doctor working in government hospital, then they can complain in department also for departmental inquiry, or with health department of government to go for inquiry with that very doctor. So there are so many areas as far as complaint part is concerned, and many times one can prefer complaint at more than one places also.
Sir, here for the criminal case, they have to take the opinion of civil hospital committee.
Yes.
Otherwise,
So in
without that,
famous case of Jacob Matthews versus State of Punjab, which was decided in 2005, and in that very case, Supreme Court came up with 3 guidelines. So to charge any doctor criminally liable, there are 3 guidelines, and if these 3 guidelines are fulfilled, then only doctor should be arrested or doctor is taken into custody. So first guideline was there should be prima facie negligence on part of doctor, and who will prove it? Relative are not medical person. Even investigating officer on part of police is also not medical person. So second guideline was there. In this type of situation, case should be referred to nearby medical college respective department, and their opinion should be non-biased. So government hospital opinion is considered non-biased. So if there is opinion from medical college of respective department that it seems to be prima facie negligence on part of treating doctor, then only police can go further as far as criminal charge of liability is concerned. But even in this situation also, third guideline was there, doctor cannot be arrested in routine manner. Because as say for example, in other routine manner, they keep handcuff or so, doctor cannot be arrested like this. So these 3 guidelines are there by Supreme Court. But PT part on that either a police person investigating the case doesn't know that 3 guidelines, or even if they know, they ignore many times and they will take doctor in custody. But if there are 2 charges, section 304 or 304A, if 304 is charged, then it is bailable on part of police station only, and bail can be granted by police station level only. If charge is from 304, then it is non-bailable and bail can only be granted by court. So, but in this situation, person who have arrested will have to prove in court of law that there was reason to believe that doctor was negligent in treating patient, which caused death of patient, and why he or she has arrested that very doctor. And it is very difficult to prove in court of law without non-biased opinion from medical person that treating doctor was negligent as far as this incident has happened.
I want to ask, add one
Yes.
more thing.
Yes,
Because
yes, sir.
Dr. Gore is from Nashik. There is one
Yes.
GR of Maharashtra government
Yes.
of 1991, where the
Yes.
same thing is said, because once we went to our SP, district superintendent, and we
Yes.
showed him Jacob Matthews guidelines. He
Hmm.
said that these are guidelines, it is not binding, because in
Yes.
Jacob Matthews it is mentioned that every state should come with these guidelines. He said
Yes.
there are no guidelines. But fortunately, in Maharashtra in 1991, the government has passed one guidelines that they cannot arrest a person without taking the opinion, expert opinion. So that is there in
So
Maharashtra.
I would like to share our experience. Long back, almost in 2003 or so, we had a very good discussion about this Jacob Matthews case at the time of one medical legal workshop. And in that very workshop, we had invited Home Secretary of Gujarat. And he was convinced that these are the guidelines from Jacob Matthews, and we requested him. So he came up with circular, and he sent that very circular to all the police station of Gujarat. And that copy of that circular is with me even today also. So if on part of association, if we can do like this, and if there could be circular on part of government to police station, then it will be much easier for us to convince investigating officer that these are the guidelines on part of Supreme Court, and these are the guidelines on part of Home Department of our respective state, and they may take it into consideration.
These copies of this GR or this document
It is available
should be,
with me.
it should be there with each rush team.
Yes, yes. We each and every nursing should have copy of judgment of Jacob Matthews, I would say. And if this type of circular is there in that respective state, then a copy of that circular should also be with each and every nursing home.
Because concerned person is very much fearful So Rush
Yes.
team should propagate this to the
Yes.
and they convince
Yes.
they should convince to the police officer there.
Yes.
So
But
he
so
will
here
not.
comes role of Rush team. Just I mentioned prior
Yeah,
also. If
yeah.
some few friends are there at your rescue in this situation, they are with sound mind. Of course, person who has dealt with that situation is under agony. But other persons have not that much agony. They can talk to police. They can try to convince police that these are guidelines, this is the circular, and matter can be taken care in this situation.
Right.
Yes. Next. Asha madam, next. You are muted. Asha madam, you are not audible. You are not audible.
अभी आ रही है?
Yes, yes. Now you are audible.
Okay. So, triathlon is like 3.9 kilometers swim, 180.2 bicycle, and 42.2 kilometer run, one by one, in one day, normally 17 hours. So it's 226.3 kilometers, and sir has completed it.
Yes.
Ironman finisher. I learned
Yes,
for the
yes.
first time what this was.
Come on, Papa! Speed up, 25, 25. Chalo,
Okay.
chalo, Ironman ki jai.
And
Come on, Papa!
good motivation for everyone. So I thought let's have a look. Does start Over to you, Shashikant sir. I really wanted everybody to see that. I hope you are still here for your question.
Oh, yes. That was really nice of you, Asha madam. And Patel sir, before I ask anything to you, wish you all the best for your next elections. And
Thank
we
you.
really pray to the God that we should get a president like you, who is
Thank
rock
you.
solid and be with us. You are real Iron Man in the medical legal field.
Thank
And
you.
now coming to the question, am I audible now?
Yes, you are
Yes.
audible.
Yeah. This is a case between Dr. Mrs. Indu Sharma versus Indraprastha Apollo Hospital. It was on 22nd of April 2015. Patient had PROM. Oxytocin was given for more than 24 hours. And then LSCS was done. 2.5 months later, the baby was diagnosed to have a cerebral palsy. Patients, they went to court. Case decided against doctor. Then exactly what went wrong and what precautions shall we take?
So almost this discussion had been prior also. As far as this cerebral palsy is concerned, so at the time of facing this type of situation, whether it was due to some antenatal region, whether it was due to something wrong on part of treating doctor at the time of delivery, or was it post delivery. So if we can prove in court of law in this type of situation, then it becomes one defense. Second part, in this type of situation, which kind of care doctor was supposed to take and whether he or she has taken that very care, and it can be proved by documentation how you have tackled with that very patient in her antenatal period, in advising all the necessary investigation, necessary treatment, follow-up treatment, etc. And at the time of labor, managing that labor as per standard protocols or standard guidelines. And if you can prove all this in court of law, even in this type of situation also, court is reasonable to decide in favor of doctor.
Sir, this case was decided against doctor
Yes, it
because
was.
oxytocin was given for 24 hours, which is
Yes.
against all guidelines.
So that is why I insisted. Patient should have been treated as per standard protocols and guidelines. If in this situation when oxytocin was given more than 24 hours or so, and in case of PROM, then it becomes very difficult in court of law to convince court whatever he did, it was as per standard guidelines.
Thank you,
Yes.
sir. So we are
Okay,
at the
thank you.
end, and we've already been 8:35 now.
Yes, right.
Dr. Monica, you are here. You want to say a couple of words before we end the session?
Yes, Monica, welcome. Please unmute.
You are muted, Dr. Monica.
Yes,
Hello.
welcome. Welcome.
Welcome. Sorry, sir, I was washed up in the OT. That is why I couldn't join in the beginning.
This is our area of practice, obstetrics.
Yes, sir.
Yes, welcome. Any comments from Monica? During my this welcome speech, I had also mentioned that Monica is instrumental in conducting this webinar, and whenever we have to go with any webinar in Maharashtra, Monica is always with me. And whenever I have called Monica, she has never said no. She is always there to help me. So thank you, Monica, for the same.
Thank you so much, sir, for the appreciation and anything for you, sir. It is an honor to be with you, sir, and it is an thing to learn that we are in the 187th episode, and the consistency does matter, sir.
Yes, yes.
So Dr.
Thank you.
Vijay Lakshmi and Dr. C.D. Mishra sir are still there. And I
Yes.
would just like to thank you a lot for being here till the very end and joining in spite of your family commitments. So, sir, if you suggest, I would like to say formal thanks and namaskar.
Yes.
Thank
Yeah,
you.
thank you. Thank you, Dr.
And thank you,
MC
Corona people also.
So
Thank you.
kind enough.
Thank you very much, sir.
Yes.
And thank you, Dr.
Because
Asha
Corona
Jain.
people are with us
Sir,
in this
Vijay
our
Lakshmi ma'am
educational.
is saying something.
Oh yes. Yeah, welcome, madam.
You know, we want to wish you all the best for your elections, both Dr.
Thank you, madam.
Patel and Dr.
Thank you,
Jain. It
madam.
was wonderful to be with you. And
Yes.
it was my pleasure. So I had decided to wait till the end. Thank you.
Yes.
Thank you so much.
Thank you, ma'am. So we are blessed. So I was going
Thank you.
about,
Thank you.
as far as
MC
Corona
Patel sir,
part is
C.D.
concerned.
Mishra sir,
Hmm.
Corona Remedies, Monica, Dr. Vikas, Dr. Prashant, Dr. Shashikant sir. I thank everyone for staying till the end. Thanks a lot. Prashant sir, I'm sorry I had to interrupt. If you want to ask anything, we can take 1 minute. You're muted, sir. You're muted.
Hello.
Yes,
Yes,
welcome.
No, everything was explained by sir very nicely.
Yes,
And
good.
all the best, sir, for your presidential
you.
election, sir.
Thank
So
you,
we will
thank you.
definitely support you, sir. And
Oh,
we'll
yes.
ask our colleagues to vote for you.
Oh yes, welcome.
From
Thank
my
you.
part, I also wish best of luck to Patel sir. and
Thank you,
Vijay.
Mishra sir.
And me for Chairperson Food, Drug and Medico Surgical Equipment Committee. Kindly support from your societies. Thank you. Thank you very much. Piyush, you may end the session, please. Thanks a lot, Corona Remedies, for being our academic partners.
Thank you so much, ma'am. Good night.
Thank
Good
you.
night.
Good night.